I'm going to be talking a little bit about hemorrhage control and some various techniques that we can use to control bleeding in different sources. No, there we go. So we're going to go over a little bit about the relevance, some hemorrhage control techniques for both external and internal bleeding. So hemorrhage is one of the leading causes of potentially preventable deaths, especially one that is amenable to intervention. And this is something that we can significantly reduce morbidity and mortality in because it's something that we can't intervene upon. Management of patients with massive hemorrhage should be focused on the basics of resuscitation, your ABCs, IV, O2 monitor, of course, and MTP as necessary. Stopping the blood loss is critical in these patients, and that's what is going to be able to lead them to survive. There are limited management options available for hemodynamically unstable patients with non-compressible or not readily accessible bleeding sites, such as those in the gastrointestinal tract, intra-abdominal, intrathoracic, pelvic, or retroperitoneal bleeds. And another important thing to remember is don't let an impressive wound distract you from a life-threatening one. So we're going to go through some other techniques now. This is really basic, but the quickest and easiest way to stop bleeding is to compress the site if it's a compressible one. There are many different compressive bandages that are available, but a lot of them apply too little pressure over too wide of an area and act more like a sponge and end up hiding a significant amount of blood loss instead of actually stopping it. We've seen this all, I'm sure, numerous times when EMS brings in a patient with like a wrap around their head and you see like there's blood oozing through, but then you take it off and you see the arterial pumper from a head wound. And mostly direct pressure over the wound allows for the body's natural hemostasis mechanisms to kick in and a platelet plug formation to form. So really just holding that pressure and being patient can be really helpful and important for these patients. And another thing is you can also apply pressure not just directly over the wound, but to a vessel that's proximal to the wound in order to have like a more bloodless field to be able to visualize where the bleeding is coming from. Sutures are a really quick and simple method for hemorrhage control, something that we use every day. If you're able to see an actual ligated vessel, one of the larger or more intermediate sized ones, you can just grab it with hemostat and pass an absorbable suture around it and tie off the bleeder directly. You want to make sure that the absorbable suture is not one that loses tensile strength too quickly. Some ideal sutures would be Vicryl, Monocryl, or PDS in these cases. Oftentimes, though, transected blood vessels, specifically arteries and arterioles, will retract into the tissue and make it very difficult to find the exact bleeding vessel. And you'll just kind of see bleeding around the whole site of where the wound is. So in these cases, figure of 8 or purse string sutures can be used to encompass the entire bleeding vessel and stop the blood flow. We're just going to hope that this video works. We're going to look at a figure of 8 suture. Oops, sorry guys. So next, we're going to talk a little bit about cautery. It can be used for smaller bleeding vessels, specifically those that are less than 2 millimeters in diameter. Cautery needs a bloodless field in order for it to work. We do have electrocautery. They're in fast track for anybody who didn't know where to find them. So just that's something that can be kept in mind. And in addition to electric cautery, there's also chemical cauterization that can be used with either silver nitrate, Monsell solution, or dry cell solution. Just both nitrate solution and Monsell solution can permanently stain the skin. So in cosmetically sensitive areas, you want to be a little bit more careful. Dry cell solution won't stain the skin, but it's also a little bit less effective. And you just need to be careful not to overuse either electric or chemical cautery because it can cause unnecessary tissue necrosis and impair wound healing. Epinephrine is a vasoconstrictor that we use quite frequently in hemorrhage control. It's very helpful with smaller bleeding vessels. It can be injected into the wound edges or even applied topically. We generally don't use epinephrine alone in these cases. It's mixed in with local anesthetics. And so we just have to be wary of the total dose that we're giving to avoid systemic effects. And you always want to make sure to aspirate before you inject so you're not injecting this into any vessels. TXA is an antifibrinolytic agent that inhibits plasminogen activation and is really good for bleeding, specifically in dental post-extraction bleeding, epistaxis, vaginal bleeding, patients with severe trauma that are also having bleeding. And it can be given either nebulized, systemically, or even topically. Some adverse reactions can be allergic, thrombosis, or toxic epidermal necrolysis. So just beware if the patient's had any of these in the past or has risk for thrombosis. There are many topical hemostatic agents that are available. I'm not going to go through all of the different brand names and stuff, but they work through a very different pathways, which are actually really interesting. Some of them provide a matrix for platelet deposition. Others activate the intrinsic clotting cascade and promote clot formation. Several contain clotting factors. There's one of them is a polymer that expands when it encounters liquids and it swells, and then the swelling can tampen out the bleed. And there's some that are polysaccharides derived from marine microalgae and crustaceans, which achieve hemostasis through multiple mechanisms, include like attracting circulating red blood cells, causing tissue adhesion, and some vasospasm. So tourniquets often actually are unnecessary, as direct pressure can be much more effective and cause less tissue ischemia and damage. But when you're strapped for personnel, this can actually be quite helpful. The application of a tourniquet, when it's applied correctly, will always cause pain to the patient. And there is no definitive safe amount of time that a tourniquet can be applied. There is always a risk of ischemia and limb loss, but oftentimes the benefits outweigh the risks if the patient is bleeding out. It is generally thought that 2 hours is safe to apply a tourniquet for. And you want to use the minimal amount of force necessary to stop the bleed with the tourniquet. Some complications can include neurovascular injury, tissue injury, bony injury, compartment syndrome, rhabdo, and DVTs. So we have a couple of different varieties of tourniquets. Here we're going to be talking about extremity tourniquets. Most of the literature that we have on them comes from the military, where civilians are closer to hospitals and providers and often have less severe injuries than those that are seen in the military. Tourniquets can still come in handy. So right up here, we have what's known as the basic windlass tourniquet. This part over here, this twisty part, is the windlass. And it's a pretty easy to use device that doesn't need any clips or knots or anything to secure it. You just basically tie it around the patient, tighten down the windlass. And this can exert up to 1,200 pounds of force, which is a huge amount. So that can stop quite a bit of bleeding. Then next we have the SWAT T tourniquet, this orange one right up here. It's basically an elastic wrap that you can just keep wrapping around the patient whatever their bleeding extremity is. You kind of apply it like an A-strap. It's really easy to use. Unlike the other ones, it doesn't have a windlass mechanism. This is the combat application tourniquet. This is the most similar one to the one that we have in CCT. And it basically is this device, you put it around the patient, it has a Velcro, you tighten it down as much as you can. And then from there, you use the windlass to tighten it down further until you're able to stop the bleeding. And over here, there's this like little hook thing that you stick the windlass in to lock it into place. And last but not least, we have the SAM XT tourniquet, which is very similar to the prior one. The only difference being here is that there's a buckle as opposed to the Velcro. And then once you've finished turning the windlass and secured it, it auto locks and takes away all of the slack. So junctional hemorrhage is defined as a hemorrhage from the junction of the torso and extremity or proximal to the extremity where a tourniquet is unable to be applied. Topical hemostatic agents, direct pressure, and are just not as successful with junctional hemorrhages as they are with extremity hemorrhages. And so there are several FDA approved devices that can be used for junctional hemorrhages. So up here we have the first one, which is the abdominal aortic junctional tourniquet. It's a belt that allows for pressure to be delivered over a prolonged amount of time to one area. You basically put this belt on. It has a windlass mechanism right here, like the extremity tourniquets that we saw before, in addition to a pneumatic device and a wedge-shaped bladder that you can inflate in order to apply pressure. This tourniquet can be used for both inguinal and axillary hemorrhages, and it can be used safely for up to 4 hours. Next, we have over here, which is our combat ready clamp. And it's designed for both inguinal and axillary hemorrhages again. And it basically exerts a mechanical force with these circular discs directly over the junctional wound or indirectly over a proximal vessel to occlude blood flow to the wound. And you use this clamp to tighten down the disc over the area of the bleed. Then we have the junctional emergency treatment tool, which is only used for inguinal hemorrhages. And it has a windlass mechanism, again, used to cinch the device over the area that is bleeding. It's unique in that it has a pelvic binder component, and you can use it to compress either one or both of the femoral arteries, whatever it is that you need at the time. And lastly, we have the SAM junctional tourniquet, which is for both upper and lower extremity junctional hemorrhages and can be also used for unstable pelvic fractures. It has this belt, which you fasten around the abdomen or pelvis, and it has 2 inflatable cuffs known as target compressive devices that are placed proximally to the injury and then inflated to occlude blood flow. And essentially, in all of these devices, complications are ischemia if left on too long and continued hemorrhage if they're applied incorrectly. So balloon catheters can be used to tamponade bleeds from deep wound tracts. So there's a couple of different ways that we can use these. So Foley catheters can be used in posterior epistaxis. You would use a 10 to 14 French Foley catheter and insert the device until it is visible in the posterior oropharynx. You'd then fill it with 5 to 7 mL of saline, and you would retract it until it lodges in the posterior choana of the nasopharynx. Pretty straightforward, and Foleys are really accessible, so it'd be a good thing to use if you would encounter this situation. And then the other thing is a Blakemore tube, which can be used as a temporizing measure to tamponade esophageal or gastric varices in cases where definitive management needs to happen but can't happen right away. So you'd consider this in a patient with an acute esophageal or gastric variceal bleed where medical therapy like somatostatin, octreotide, or vasopressin, or if emergent endoscopy is not available or is contraindicated, or even if it's unsuccessful at the time. So the Blakemore tube is a triple lumen and double balloon system. The proximal end contains 3 ports, which we see right here. And there are 2 balloons at the distal end. One of the ports is the gastric port, which can be used to aspirate gastric contents, insert stuff into the stomach, or lavage the stomach. And then you have your esophageal port, which goes to the esophageal balloon, and your gastric port, which goes to the gastric balloon. The gastric balloon is rounded, whereas the esophageal balloon is much more elongated. And the end of the catheter has fenestrations so that you can allow for gastric lavage. So when the balloons are inflated, the esophageal balloon will exert lateral pressure to tamponade bleeding esophageal varices, where the gastric balloon will exert pressure on the gastric cardia to tamponade bleeding varices there. When both balloons are inflated, they meet to compress the gastric cardia against the diaphragm and block upward flow of collateral blood from feeding the esophageal varices. Some absolute contraindications to these would be patients who recently had surgery at the GE junction or have a known history of stricture of the esophagus. And these esophageal balloons should not be inflated for more than 24 hours to avoid mural necrosis. Some complications include esophageal rupture, mediastinitis, aspiration, and a concern is if you haven't taken this patient's airway and the balloon migrates, it can cause significant respiratory distress, and this tube should be immediately removed from these patients. We're just gonna watch a video on how this balloon is placed.
I have tied a stitch around those stopcocks and tied it tight like silk just to make sure they stay in. Sometimes it's hard to get them to stay on, they pop off. Okay, oops, sorry. So last but not least, we're going to talk about some endovascular devices.
Aortic occlusion is one hemorrhage control method that temporarily stops non-compressible torsal hemorrhage from injuries that receive blood supply from the subdiaphragmatic aorta. Aortic occlusion can improve hemostasis, preserve coronary and cerebral perfusion, and improve hemodynamics enough to allow for definitive hemorrhage control by embolization, endoscopy, and surgical repair. We're going to talk about Reboa now, right, for a second. And it has less physiologic disturbance and higher rates of success than cross-clamping the aorta via a thoracotomy. It's less invasive, so it's something that we might want to consider. So indications would be life-threatening intra-abdominal or pelvic hemorrhage where immediate operative control cannot be obtained. So for instance, if somebody's practicing not in a level 1 trauma center where we have our surgeons, that'll come really quickly. And we can use it to bridge to definitive treatment, but there is no high quality evidence to support its use. It can be used in traumatic arrests from penetrating trauma to the abdomen or lower extremity or pelvis with less than 15 minutes of CPR time, traumatic arrests from blunt trauma with an organized rhythm on EKG or cardiac activity on fast, or in patients that have hemorrhagic shock from non-traumatic etiologies, for instance, during repair of a AAA, rupture of an ectopic pregnancy, postpartum hemorrhage, or an upper GI bleed. Reboa is introduced through the femoral artery, and proper placement in the thoracic aorta is estimated by measuring the distance between the inguinal crease and the mid-sternum. For the Reboa, the aorta is divided into 3 zones. Zone 1 is the area distal to the left subclavian artery and proximal to the celiac trunk. Zone 2 is a 3-centimeter area of the aorta distal to the celiac trunk and proximal to the last renal artery. And zone 3 represents the aorta distal to the renal arteries and extends to the bifurcation of the common iliacs. We generally want to avoid zone 2 due to the possibility of not occluding the vessel of interest, and it also holds really no advantage of just going into zone 1. There is no definitive safe time to apply Reboa for. There is a risk of ischemia and aortic injury every time we use it. So obviously the less amount of time, the better. 60 minutes is generally thought of to be safe, but rates of organ dysfunction and failure, specifically kidney failure, increase significantly after 90 minutes. So risks include bleeding, damage to surrounding structures, and infection. One complication that is unique to Reboa is aortic rupture due to overinflation of the balloon. You especially want to use caution in patients with peripheral vascular disease or prior femoral artery procedures because their anatomy is more complicated and this increases the risk of complications. So we just went over a lot of different techniques to stop the bleed. Basically a summary. So ideal goals in wound care would be to achieve a dry bloodless field without compromising the vitality of the tissue. Controlling the hemorrhage and preserving life is a really awesome goal in major trauma victims. And I guess like a smaller goal in those everyday smaller bleeds that we get would be expediting wound closure and preventing hematoma formation. So here are my references and any questions.